is the resectoscope that we are inserting. Here we can see one single fibroid at the level of internal os. If we go above that, there is one more intrauterine fibroid measuring 3 by 2 centimeters. And it was removed with the help of resectoscope. In this case as well, hysterectomy was avoided. Now this is a case of postmenopausal bleeding, 52 years old patient, and there was endometrial hyperplasia on sonography. So we did hysteroscopy with endometrial sampling, and the histopathological diagnosis was papillary endometrioid carcinoma. In this picture, we can see that there is something different over here. This is not the normal looking endometrial cavity. So we were sure during the procedure only that this is some kind of cancer. We waited for the histopathological report, and the report came to be papillary carcinoma. Now this is hysteroscopic polypectomy. A small polyp 2 by 2 centimeters. It was removed with the help of scissors. In case of infertility, this is a case of septum, intrauterine septum. Here we can see that there is a very small uterine cavity that is present because of the intervening septum. And this septum was corrected with the help of resectoscope. And we can see the difference between two uterine cavities. More than 20% of the cavitary place has been increased because of this procedure. The total septum is resected. Now this is the one case, 26 years old one, para one living one. She had intermenstrual PV bleeding with dysmenorrhea since 4 months. Patient had done 3 sonographies outside, so we directly posted her for hysteroscopic myomectomy instead of repeating sonography. Intraoperatively, we found something different, that this is not myoma, but we had to take the tissue and send it for the histopathology. So the tissue was resected and sent for histopathology, and the diagnosis came out to be placental site trophoblastic tumor, which is one of the worst tumor in case of placental site trophoblastic tumors. Hysteroscopy can be used to unblock the fallopian tubes. This video shows that there is cannulation set, white color cannulation set. Inside it is guide wire which has been put through the ostia, and the same guide wire we can see on the laparoscopy that is coming out of the fallopian tube. And the dye is inserted through the vagina and the tube was opened. Laparoscopy is a surgical procedure in which a fiber optic instrument is inserted through the abdominal wall to view the organs in the abdomen or permit the surgery with the help of pneumoperitoneum. At Penicare, we have 3D 4K Stores Rubina camera and a good laparoscopic team. Composition of a laparoscopic system: the equipment card, insufflation system, electrosurgical unit, imaging systems, different instrumentations, suction and irrigation systems. Varese needle, it is one of the instrument which is used to inflate the CO2 inside the peritoneal cavity through the thinnest part of the abdominal wall. This is CO2 insufflator which insufflates the abdomen with the help of CO2. These are the trocars through which different instruments go inside the abdominal cavity. This is one of the endoscope, that is laparoscope. It has different angles and different sizes. each with a different use. This laparoscope, it is used to visualize the peritoneal cavity. Instrument can be disposable or reusable. In India, we usually use reusable instruments, and they can be either traumatic or non-traumatic. Now, why laparoscopy? The advantages of laparoscopy: less post-operative scarring, so more cosmetic, reduce pain and shorter recovery time, less time spent in hospital to recover, minimize bleeding, reduce risk of exposing internal organs to external contaminants, quicker return to normal activities, and reduce wound infection and other wound complications. Applications of laparoscopy: it can be used as a diagnostic tool or a therapeutic modality. The indications of laparoscopy in gynecology, vast numbers are there. It can be used as a fertility enhancing surgery in case of endometriosis, myomectomy, total laparoscopic hysterectomy, in case of ovarian cyst or benign ovarian tumors, para-ovarian masses, ectopic pregnancy, endometrial cancers. In sling surgery, in case of uterine prolapse, we use sling surgeries, adenomyomectomy, diagnostic histolaparoscopy, chromoperturbation and cannulation, isthmocele repair, scar ectopic pregnancy management, tuboplasty, that is family planning operation has been done previously and we have to reverse it, adhesiolysis, family planning operations, hydrosalpinx, acum, ovarian drilling in case of PCOD, aspiration of ovarian cyst, scar ectopic pregnancy. The complications of laparoscopy: they are perforation of the bowel, major abdominal vessels injury, and vessels of anti-abdominal wall injury. The contraindications, very few. Some of them are severe cardiopulmonary diseases, generalized peritonitis, intestinal obstruction, significant hemoperitoneum and hemodynamically unstable patient, extensive peritoneal adhesions, large pelvic tumors, and obesity. Obesity is a relative contraindication. Few case studies. Now this acum, it is also known as accessory cavitated uterine mass. So this patient, she came to us with menstrual pain since menarche. She used to take injectable painkillers every monthly. Severe separate laparoscopic surgeries were done for her. One for appendix when she was 15-16 years old, and other for perhaps diagnostic histolaparoscopy. Multiple UHS scans and MRI was done with no abnormality detected. In Penicare, we suspected the acum and we advised patient for histolaparoscopy. And on laparoscopy, we could see that this portion is there, and that is the acum. That we can simply say that there is a small uterus inside the uterus. Now, normal uterus, it bleeds through internal os and vagina, but this acum, it doesn't have outflow tract. So the blood gets accumulated inside the mass, and that's why the cyclical bleeding comes. At the same setting, she was corrected of this anomaly, and this is the acum we removed. Later on, the rough surface was sutured. Then, in case of ruptured ectopic pregnancy, this was a case where left-sided fallopian tube was removed because of the ruptured ectopic pregnancy. Now, this is another patient. Usually, a patient comes to us. Sometimes, some doctors they advise MTP kit directly. This patient had that MTP kit without doing any sonography, and there was torrential bleeding inside the abdominal cavity, and more than 3 liters of blood was removed from the peritoneal cavity. So meso or mifepristone should not be given blindly; it should be given only after doing the sonography. Now, the role of laparoscopy in cervical encerclage. This is a patient, 26 years old, and she had previous 2 abortions, second trimester abortions. In this case, laparoscopic cervical encerclage done, and patient was delivered at 36 weeks of gestation. Now, this is the Marcelin tape which is applied around almost around the level of internal os, and in this case, patient was delivered with cesarean section at 36 weeks. Now, this is a case of multiple fibroids with infertility. Laparoscopy was done and 13 fibroids were removed, In this case, uterine artery was secured at origin so that even with when we were removed 13 fibroids, the blood loss was less than 15 cc. Patient was discharged within 48 hours. One fibroid anteriorly, two in the left cornea, and smaller ones, and in the POD also 4 to 5 fibroids were there. This is securing the uterine artery at origin. Ureter is nearby and we are securing the uterine artery. Perhaps this is possible or looking simple because of the new system that we are having. This is a patient 24 years, unmarried. She came to hospital with fever on and off since 2 weeks. On CT scan, multicystic lesion was present, measuring 12 by 12 centimeters. Under laparoscopic vision, a mass of 20 by 15 centimeter was seen on left side arising from the ovary. Tumor markers and other things were normal. So retorsion was done and multisystem lesion was excised, preserving the appreciable part of the left ovary. Both ovaries and fallopian tubes were saved owing to preservation of the fertility. Her post-operative AMH after 2 months was 3.2, which is quite good in this case. This was the tumor, and this is the remnant ovary that we were able to preserve from the left side. Now this is a case of grade 4 endometriosis, para 1 living one complaining of menorrhagia with dysmenorrhea since 6 to 8 hours. Here was presence of on sonography, endometrial cyst was there, measuring 10 by 8 centimeters with left hydrosalpinx and the right ovarian cyst. Histolaparoscopy was done, right ovarian cyst 2 by 1 centimeter, cystectomy was done and ovary was saved. Left ovarian cyst 15 by 7 centimeter was present. Endometriotic patches were present. Right fallopian tube normal, it was preserved, and left fallopian tube hydrosalpinx was present, measuring almost 6 by 5 centimeters. It was removed. Now this is the case of this endometriosis where we can see uterus, fallopian tube, and ovaries both are cemented together. We can't even see the pouch of Douglas. Uterosacrus, it was also adherent, and this is the end results of the surgery where we were able to do retroperitoneal dissection on the lateral pelvic wall. We had to do ureterolysis, we had to do uterine artery at origin, and then we have to remove the tube and ovary. Now this is a laparoscopic cystectomy done for large uterine fibroid. 35 years, mentally retarded, 11 by 12 centimeters fibroid was there. So hysterectomy was done for the mentally retarded. If you can see, the fibroid is starting from here till it is obliterating the POD. It is going over there. Laparoscopically, we thought that it is around 18 by 15 centimeter, and it was removed laparoscopically only. Again by suturing uterine artery at origin. The uterine mass was around 1700 grams. This is a sling operation pectopexy, where in uterine prolapse we operate 2 pectineal ligaments that are present on the pubic bone to the uterus, to the cervix. Endometrial carcinoma, the same case that we discussed about in histoscopy, papillary endometrial carcinoma was there. So hysterectomy with pelvic lymph node biopsy was done. Laparoscopic myomectomy with ovarian cystectomy. Patient had acute abdomen, so she came to us in the afternoon. So on sonography there was some ureteric stone. Along with that there was 8 to 10 centimeters fibroid. There was ovarian tumor cyst, chocolate cyst on the both sides. Along with that, one tube was blocked. So multiple operations were done in this patient. Laparoscopic myomectomy with both sides, cystectomy with histoscopy and cystoscopy and URSL and derestenting. This is the myoma that we removed, and this is the chocolate cyst, and the end result was something like this. Here also we did uterine artery ligation at origin. Blood loss was very minimal, quite minimal. Thank you.
Thank you so much, Dr. Jaideep, for a wonderful presentation.
Thank you, sir.
Thank you, Dr. Sir. Jaideep Palwade, sir, with such an insightful, knowledgeable, and with lot of varieties of clinical cases. I should appreciate your surgical skills, definitely. I